So good evening, everyone, and welcome to the third in our menopause series, which is going to be about the genitourinary syndrome of the menopause. My name's Deborah Evans, and I'm clinic director and owner of Remedy Health. So welcome. I'm going to share with you this evening, I hope, lots of information, and do participate by asking questions. It's difficult in this kind of webinar scenario to be interactive, but I know you're out there, and please do feedback with any questions during the course of the evening. So Remedy Health, we're an independent private healthcare clinic and pharmacy. We opened in December 2021, fulfilling a passion of mine to really support individuals and empower them around their health and well-being, and give them solutions that they can really buy into. And what we're able to do, because we're a pharmacy and we have prescribers on site, is offer diagnostics, consultations, support, advice, but also with medicines if needed. And so we're really proud of how the business has developed and our practice has grown. Now, we're led by pharmacists, and I myself have been a pharmacist for probably around 36 years. That does make me almost 60, and I'm a mother of 4, grandmother of 3, and I've been through both the perimenopause and I'm now postmenopausal. So hopefully able to give not just my insight as a clinician this evening, but also as an individual who has certainly had her ups and downs during this whole process. We pride ourselves on having relationships with other healthcare providers and often supporting women during this really important time of their lives requires a multidisciplinary approach. And I'm going to talk about referral and when that's appropriate later on this evening. So we do love to see people face to face here in the clinic. It's a beautiful space, and we've won awards for the innovation, but we also do undertake remote consultations for those of you that might be further afield from our location in Winchester. So let's get on to the meat of tonight and what GSM is and why it occurs. So we're going to talk about the pathophysiology and anatomical changes associated with what's happening down there below our waist. We're going to talk about the prevalence and impact of this condition, what symptoms we can expect, and importantly, how we can get support, treatments, both in terms of things we can buy over the counter, lifestyle things, and also hormone replacement. I mentioned earlier, we're going to talk about when things might require a referral, and overarching and underpinning all of this is how we keep healthy. I'm going to be recording this evening. As I mentioned earlier, I really want you to participate as much as you can do, being on the other end of the screen there. And so do pop your questions in the Q&A. Hopefully you'd see that icon on your screen. The recording will be made available to you within a week, and you can either look at it again or feel free to share it with others that you think might find it helpful. So let's start, well, with the menopause and the perimenopause. GSM, or genital urinary syndrome of the menopause, is one of the most consistently identified predictors of our sexual health and impaired sexual health in women. And it's also almost default going to happen as you go into the postmenopausal period. Now, the menopause is caused by a change to your hormone levels, and as you approach your last period, those levels of estrogen, which you've had throughout your reproductive life, fall, your ovaries stop releasing eggs each month, and eventually your periods stop. Now, we know that the hormonal changes that occur during the menopause cause a variety of physical and psychological symptoms across our whole body. We've got estrogen receptors across from our brain, joints, heart, skin, everywhere. And we also have them in our vulvas, vaginas, and in our bladders and urethra. So we're going to really explore that this evening as to focus on that particular area and for us to think about how we optimize the health of your bladder, vagina and vulvas during this time as estrogen changes and declines. And I think this chart, I've shown it on the last two webinars. I make no apology for it because I think it really effectively shows what's happening to our hormones during particularly the perimenopause. You'll see that top line is estrogen, and during the perimenopause, our hormones fluctuate hugely and cause all sorts of difficulties. And some of you may be experiencing that, or certainly have experienced it. Some women sell through and don't notice, but for many, it's a time of real physical and psychological turmoil. Out the other end of that, when our periods stop, you can see that our estrogen stabilizes, but at a very low level. And particularly in our previous webinars, we've talked about the impact that low estrogen can have, particularly on our long-term health and the risk of cardiovascular disease, diabetes, dementia, osteoporosis, and some cancers. But that low estrogen also has a significant effect on the anatomy of our vaginas, vulvas, and in that whole pelvic region. So let's just explore a little bit more about what GSM, or genital urinary syndrome of the menopause, includes. It's now the term that's including all of those vulvar and vaginal symptoms and lower urinary tract symptoms. So the bladder, and we'll talk about exactly what that looks like and feels like, but related to low estrogen levels that we've already discussed. And I think it's fair to say that the vast majority of postmenopausal women, particularly women who've not been exposed to HRT, systemic, what we call systemic HRT, have symptoms associated with GSM, and yet only a very small minority receive any treatment. Now, the term GSM, I'm going to use it abbreviated throughout the course of the evening now, is recent, and it was introduced less than 10 years ago. Previous to that, the terms vulvar vaginal atrophy, atrophic vaginitis, vaginal atrophy were used. They really sort of grate, don't they? They don't feel at all attractive, a dry vagina, and they're not ideal because they don't cover the full spectrum of symptoms that are related to these low estrogen levels in the menopausal state. So this term GSM much more accurately describes what's happening, particularly in the postmenopausal, hypoestrogenic, so low estrogen state of that whole genital urinary tract. So it includes conditions of the vagina, the vulva, pelvic floor tissues, our urinary tract, so our urethra. It also can include sexual dysfunction and loss of libido. And of course, it's difficult to know where one starts and the other finishes. Certainly, if you're uncomfortable, there's pain, that you really don't feel attractive in that area, that's potentially going to lead to loss of libido and sexual dysfunction. And we'll explore that a little bit as well later on. So in summary, really, GSM is defined as being a progressive and chronic condition, and it's caused by the loss of estrogen. And it's almost an inevitability, and we'll explore why. But first of all, who is more at risk? Well, if you've gone through a menopause, and particularly if you're not on HRT or haven't been on HRT, if you've had your ovaries removed, or if you've gone through a premature ovarian failure. So in other words, your ovaries have failed for a number of different reasons, whether that's just spontaneous, genetically linked, or due to treatment. And that would be a menopause before the age of 40. Smoking certainly increases the risk. It decreases the integrity of blood vessels, and anywhere where we've got low blood flow, we're going to have lower integrity of tissues. Alcohol abuse similarly, and actually not having sex can also increase the risk of this condition, and particularly abstinence. If you've not had a vaginal birth, that also increases the risk. And then there might be other reasons for low estrogen, and that might be if you've had children quite late and you're in the postpartum period. There may be other conditions linked to stopping periods that may also cause low estrogen. And also treatments, for example, the anti-estrogens or estrogen blockers, which are a class of drugs which are typically prescribed following breast cancer. So these are things like anastrozole and letrozole, as well as tamoxifen. And then cancer treatments themselves can increase the risk, including pelvic irradiation, chemotherapy, and other hormone treatments. But if you don't find yourself on that list, it doesn't mean you're not at risk. And we do know around 70% of women have symptoms of genital urinary syndrome of the menopause, and yet only 7% receive treatment. So it is very common and often underdiagnosed and undertreated. Now, despite the fact that most of us will experience symptoms, only around a quarter of us will say anything to a healthcare professional. And on the flip side of that, 70% of healthcare professionals have acknowledged that they never or rarely ask about problems such as vaginal dryness or urine leaking, both symptoms of GSM. Both women and healthcare professions frequently look at this as just an unavoidable part of aging. I was looking into some more information around this. I think this is fascinating, and how we can empower women to speak more about the conditions that they're facing, which can have a significant impact on their lives. And there was a study done in Australia around this whole area, the impact of GSM on health and particularly quality of life. And what was found there was, first of all, the prevalence of vaginal dryness, in particular, increased with age. So around 4% of women in this study experienced problems in their early perimenopause. Around a quarter would be at the 1-year mark post-menopause, and then around half of women 3 years after the menopause. And it just progresses from there. So, for example, we know over 70% of women aged older than 70 years old will have symptoms associated, and they frequently present with recurrent urinary tract infections, for example, given antibiotics, sometimes put on antibiotics long term, when actually their symptoms and the increase in UTIs is associated with loss of estrogen at menopause. And I think at this point, it's important to say that these symptoms can be incredibly debilitating, and yet women are still not presenting to talk to their healthcare professionals around that. So something definitely has to change, and the more awareness amongst healthcare professionals, the better. So if we think about what's actually happening and why do these changes occur, we've already said that GSM is caused by low estrogen, but why does it have such an impact? Well, we have estrogen receptors, so, responding to estrogen as a hormone in our vaginas, in the whole of our vulvar area, our urethras, which is the tube that goes from the bladder to the outside, our bladders itself, and then a lot of the nerve cells, both those that respond autonomically or automatically to signals, as well as sensory nerve cells, so how we feel, and that's why the area can be so painful in our vaginas and vulvas. There are also testosterone receptors in this particular area. So as our estrogen goes down, we start to experience both anatomical and functional changes, and this leads to the physical symptoms that we get. So we lose collagen and elastin, we have changes to the musculature in the area, our blood vessels reduce, and therefore, if we've got reduced blood flow, we get a pallor, and at the same time as losing this sort of elasticity and the plumpness that collagen gives us, we also get an increase in connective tissue. And this leads to a thinning of the skin in the inside of the vagina and on the vulva, around the urethra, lower blood flow, and the whole thing gets thin. And coupled with that, we produce less of the secretions, and so everything becomes drier. So you can see in this picture, if you're looking at a screen, that the vagina before the menopause is well estrogenized, it's lubricated, it's plump. There are lots of those sort of bends in the outside of the vagina going across the vagina. But in the post-menopausal vagina, the vaginal tissues become dry, sometimes paper thin, and you can end up with, in fact, capillaries breaking on the surface of the vagina and getting some spotting and bleeding as a result. And if you think about the skin at the rest of our body, you know, we know, looking at the backs of our hands, looking at our faces, across our body, the same changes are happening. We're losing collagen, our skin's becoming less pliable, less elastic, we're developing wrinkles, the skin's thinning, and so it's no surprise that that's happening in that area as well. So we've already started to explore some of the symptoms: dryness, loss of lubrication. This can lead to painful intercourse if you can, in fact, have intercourse. Sometimes women just can't. And that actually includes simply being able to have a smear test. Can be a really important sign that the changes are happening in this area. Vaginal wall prolapse can occur, vaginal bleeding, discharge, burning, dryness, irritation, itching. Some women experience recurrent thrush symptoms, and that can be sometimes that this itching and the irritation can be misinterpreted as thrush, but also the change in pH and the environment in this area can also lead to an overgrowth of Candida thrush. And so that should be certainly an indicator to women if they're experiencing more frequent thrush infections, and to healthcare professionals, actually, urinary symptoms as well, in terms of recurrent UTIs, urinary tract infections, that sort of sensitivity that you get in your bladder, and then you sit down to have a pee and nothing comes out, or you have to really squeeze it out. Sometimes an urgency that can lead to leaking before you get to the toilet, stress incontinence, jumping up and down, or sneezing, coughing. It's all about losing tone in that important tissue. And sometimes women get pain when weeing, and sometimes find it really difficult to empty all of their bladder because the muscular tone in that whole pelvic region is declining. Just sort of explore, we're going to sort of touch on sex throughout this presentation. I think it's a really important topic to have, and often one that's not explored when we're talking about women's health. There may be loss of libido that may be associated with other hormonal decline, but also pain on entry, pain during the intercourse, pain after the intercourse, perhaps more frequent cystitis symptoms after intercourse, and indeed our lowering testosterone in our bodies generally, together with these changes, means that arousal and orgasm may be much more difficult to achieve. And frankly, if you're not enjoying it and it's painful, why would you want to? So that can then lead to relationship issues and just not feeling good about yourself. I mean, sexual health, enjoying sex is such an important part of who we are as individuals, that some of these physical issues, which can be easily dealt with, are important to have on the agenda. Some women present because they have bleeding or spotting after intercourse and get very worried, of course, because it is a red flag symptom for more serious issues, but frequently it's because of these very delicate blood vessels at the very edge of the vaginal wall. And then I mentioned prolapse briefly, but certainly that fullness and pressure in the pelvic and vaginal area, and aching and discomfort, further urinary problems, stress incontinence, painful sex, all of these are indicators that an examination is required, and a referral to check that the prolapse, which is very common, where either bladder or uterus can drop, needs to be dealt with. So having said all of that, it's no surprise that the impact of GSM can be huge. Physically, the vaginal dryness, soreness, irritation, burning can really affect daily activities, including just simply walking, wearing underwear. I've had women who have got so sore that they can't wear pants. Doing exercises, riding a bike becomes out of the question, horse riding, those sorts of things, just not possible. Of course, we've talked about pain during intercourse, but this has a major impact on sex life, and it can often lead to avoiding sex altogether. Issues with sleep, incontinence, bladder sensitivity. People become very reluctant to go anywhere where they can't be sure there's going to be a toilet nearby, so that can make them avoid certain activities and simply not go out. So all of this is having a massive impact on women. And when you think about how common it is, if we had a room of 10 of you together, and I mean, I can see that there's at least 30 of you listening in this evening, and the fact that you've chosen this topic means that the majority of you will be experiencing a degree of GSM, and it's such an important topic to get right. Emotionally, we know this can have a significant effect on the quality of life, not just of women, but of their sexual partners, and will have an impact not just on intimacy, relationships, but also a sense of emotional well-being and self-esteem. If all the other symptoms of perimenopausal or menopausal weren't enough, this really does make us feel old, less sexy, not ourselves, interfering with every aspect of our lives. And I think it's worth mentioning as well that society's view about women's sexuality at older age also has an impact on our willingness, I think, to talk about what's happening to us as individuals. And maybe we just think, okay, let's just stop. We'll get on with it. Knuckle down. That's what I hear from women. And it's only by healthcare professionals being really proactive and engaging women in some of these conversations that the woman will feel more comfortable to talk about it. So one survey, and this was done in the UK, of 1,000 menopausal and postmenopausal women showed that 61% reported interference with intimacy, over 2/3 with sexual satisfaction, 2/3 again with sexual spontaneity, and over half were having issues with their relationship with their partner as a result. And yet we know if we successfully treat GSM, and it is really quite straightforward to treat, not always completely, and we're going to talk about that, but in many we can regain a lot of the normal, as in earlier function of that area. And from a healthcare professional point of view, some of the information that we've had from women is that there is a disparity between the number of women who experience these symptoms and those that are treated, a significant disparity. We talked about 70% of women postmenopausally having these symptoms, and yet only 7% having treatment. So what can we do to treat GSM? Well, I'm going to explore a number of different approaches. We here at Remedy Health always look at individuals' health holistically, looking at sort of clinically and evidence-based treatments, as well as other things that we can all do to help ourselves. So I'm going to explore all of those. And I think the most important message is to say that if you have symptoms of GSM, it is possible to improve your vaginal health, the whole area of your genitourinary system, and therefore your quality of life. The treatment that we would propose depends on symptoms and signs and the degree of severity and how long someone's been having symptoms. but it is really important to say that everybody is an individual. So tonight, I'm going to give you some general approaches to treatment, and individual discussions have to happen in a one-to-one consultation, of course, as you'd expect. So first of all, there are non-hormonal therapies, which include lubricants, vaginal moisturizers, and increasingly vaginal laser, although the long-term safety and efficacy have not been established of laser treatment. And then hormonal therapies. Since GSM occurs because of estrogen deficiency, the most obvious thing to sort it out is to replace that estrogen. So hormonal therapies include vaginal estradiol cream, pessaries, tablets, vaginal tablets, that is, a ring, or I should say, this systemic hormone therapy. So you'll know that as usually gels, patches, spray, replacing the estrogen systemically. So what we're aiming to do, if we focus on hormone treatment, localized hormone treatment in the first instance, is to replace the estrogen that's being lost in those tissues. And actually local hormone treatment, so in other words, applied in the area, on the vulva, in the vagina, can be very effective in restoring the natural anatomy and resolve solutions. Now, HRT, as we know it, with patches, sprays, gels, can also be very effective when given to women to help with GSM symptoms. And frequently when we're talking to women in our menopause consultations, we find that women who've come to us because of the broader symptoms associated with the perimenopause and menopause may have a degree of genital urinary symptoms, and actually they go away. We monitor them over time, and those symptoms go away just simply with systemic HRT, so applied to the skin. Some women, however, need more help, and some women can't or don't want to use HRT. And so local estrogen therapy can be really, really helpful. I'm going to now explore the use of low-dose vaginal estrogens. We are actually running a webinar on HRT specifically in 2 weeks' time, so do sign up to that. So I'm not going to focus on that side of treatment. What I'm going to do is now focus on the vaginal estrogens, or I should say vulva estrogens as well, because we can apply creams to the outside area as well as using them internally. So low-dose vaginal estrogens, there's a range of different formulations and strengths. Response is usually rapid and sustained. So we would usually expect women to have a significant and noticeable change around 3 months after initiation of treatment. And for some, it starts before then. And what replacing the estrogen in that area does is restore normal acidity, pH levels, thickens the skin and the epithelium, and increases the blood flow to the vagina. It improves the musculature, which helps actually, because if there is some urinary incontinence, it helps that whole area respond better to pelvic floor exercises, for example. Women have fewer urinary tract infections and urinary symptoms, so that sort of feeling of wanting to go wee when you go, there isn't anything there, that decreases. And so it can be super helpful in simply restoring Mother Nature to where she was. It is preferable to start treatment as soon as symptoms start to occur. Some of the more serious developed cases of GSM, I think it'd be fair to say it's very difficult, if not impossible, for the anatomy to return to normal. So the sooner these preparations are used, the less likely it will progress to a really quite serious case. But having said that, women who are experiencing quite significant symptoms can get some real relief from using topical local vaginal estrogens. Now, I want to give you some tips as well about how to use these. But before we do that, I just want to talk about the different types of vaginal estrogens that are available. As I've mentioned already, they can be used internally, and in that case, they're used as a pessary or a little tablet that would be inserted using an applicator. There's a ring that can be used over a 3-month period, which releases a low dose of estrogen into the area, so you don't even need to think about using it. And then there's cream and gels that can be used both internally using an applicator, but also on the outside vulvar area. Now, sometimes symptoms don't improve with vaginal estrogen, and in that situation, we would check to make sure that it's being used correctly, and it is being used because it is easy to forget once you get into the twice weekly routine, and I'll talk about that in a moment. It may be that the dose isn't high enough. It may be that the preparation needs to change. There are some other hormone preparations that can be used that can be very effective, or it may be that using patches, gels, systemic HRT together with local treatments is needed just to really boost the estrogen. So we do check that. There's also a possibility that there's something else going on. And I'm going to touch on a condition called lichen sclerosis in a moment. And it is possible to have GSM and lichen sclerosis as kind of cohabiting conditions, which can mean that vaginal estrogens alone are not going to deal with some of the symptoms. Where we know somebody has responded to vaginal estrogen, but they possibly haven't got quite the response they need, if they're using systemic HRT, then it may be that we increase the number of treatments. So they use a pessary and the cream, and sometimes we increase the frequency of using the preparations. So once you're into a twice weekly sort of maintenance dose, it may be for some women that's not enough and they need to use it more frequently. Now, I think it's really important to say that women who use vaginal estrogen, even in the long term, don't need to take progestogen to protect their uterus. I know those of you using HRT systemically who've still got your uteruses will be familiar with something called micronized progesterone, and you'll be taking that probably at night. That's to protect your uterus from the inevitable thickening that would happen from estrogen if you weren't taking the progesterone. Because the dose in a vaginal estrogen is so super low, a progesterone isn't needed, unless, of course, you're on a patch, gel, spray, etc. I also want to reassure you and perhaps urge you not to read the information product leaflet, because the information put into leaflets is a requirement of the regulator, but is based on systemic hormonal preparations and can scare the life out of you. And these are very safe treatments. The amount of estrogen in a little pessary is so small that a year's worth of dosing is equivalent to one oral estrogen HRT tablet, and that's less than a pill, the contraceptive pill. So it is a very, very low dose, but because it's working in the local area, it can be very, very effective. So there are situations where local estrogen therapy can be really, really useful. And we've mentioned urinary symptoms, and it seems a bit odd that applying something into your vagina can help with how your bladder and your urethra function, but it does go into the whole sort of local area and improves the tone of the pelvic region. So it can be very, very helpful. And now, for those of you looking at the screen, you'll see there that there's a point that women with a history of cancer can use vaginal estrogen if required and if beneficial. The dose is very low and it can be very, very helpful. Obviously, you do that in consultation with a healthcare professional who's qualified to give you advice. But I think it's a very reassuring piece of information because women who, as we've said, are already on some of those anti-estrogen medicines are experiencing even worse symptoms of GSM on top of everything else. So, how do you use your vaginal estrogen? Again, forgive me, vulva as well. The usual loading dose is to insert a pessary every night for 2 to 3 weeks and then switch down to a maintenance dose of twice weekly. And I would choose a couple of days of the week, like Monday and Thursday, when you remember that, you're going to do it. As I mentioned already, it may need to be more frequent for some women. Some women need it every other day. And you can use pessaries and cream internally. And in fact, you can use cream as well as pessaries. And some women need both, particularly if their vagina is particularly tight and dry and sore. Inserting a pessary with an applicator can be really painful. So using a cream as well, just to really moisturize the area, can be super helpful. And if the external area is itchy and sore, then using the cream can be very nourishing and just feel good. And one tip would be, if you can remember this, because I'm sure once I've put it in the fridge, put your cream in the fridge. Once you've done that, you'd probably forget about it and forget to apply it before you go to sleep. But if you're particularly sore or burny skin, having a cold cream on the outside can be super, super soothing. Now, if you sort of get your symptoms resolved, the worst thing that you can do is stop treatment, because your symptoms will come back. You need to use this treatment forever. So it's one of those situations where the beneficial effect can only last whilst you're using the treatment, but there's no problem with using it forever. So the beneficial effect can take a few months to really kick in. Some notice a difference within a few weeks. And once you stop treatment, your symptoms will return. And there is usually absolutely no need to stop treatment. And I would say once you've had an initial review after 3 months, then local estrogen could be put on a repeat prescription, but you can also buy some local estrogen from your community pharmacy as well, and I'll talk about that. One thing to say about sex, because you might feel like having some sex if things are returning to normal, is that it's worth avoiding sexual contact for a few hours after application, or maybe waiting until after you've had sex, and instead use a vaginal moisturizer and lubricant. And I'll talk a little bit about those now, because there are some non-hormonal treatments, and these can be used alongside your vaginal estrogens. So lubricants and moisturizers, they are two different things. They can be very effective in relieving discomfort, friction, and are intended for use with any sort of penetrative activity, sex, pelvic exam, cervical screening, that kind of thing. And lubricants are used at the time of intercourse, whereas moisturizers provide longer-term relief from the symptoms of vaginal dryness. And I just think it's fascinating that we spend a lot of time thinking about the creams that we're putting on our face and how we maintain a youthful appearance on our skin, external skin, but we don't think about using a moisturizer in the vulva and area to keep things nice and moist and intact. So I would absolutely recommend, even if you're not experiencing symptoms of GSM, the use of vaginal moisturizers and potentially lubricants. So what's the difference? Well, moisturizers rehydrate very dry tissues. They change the fluid content in the skin lining the vagina. They absorb to it, they adhere to it, and they mimic our vaginal secretions, and they lower the pH, so a much better environment. The effect can, with specialized moisturizers, last about 3 days. Just be careful. Some we can certainly recommend certain products here if they've got particular what we call osmolarity and pH and additives, they can cause some stinging. So using a proper moisturizer designed for the vaginal area, vulva area, is really important. So brands like Yes Silk and Regel are very good at not causing irritation. They don't restore your normal physiology. You can only do that with estrogens, but what they do is present a non-hormonal solution for individual reasons if somebody wants to avoid estrogens, but they can also use side by side. And by that, I mean not at the same time, on different days, but you can use vaginal moisturizers on one day, and then you can use your vaginal estrogen on another. Lubricants. Now, lube are what we use to potentially help having sex. They can be applied to the vagina, vulva, penis prior to sex. They prevent friction. They can be used with sex toys. But what I would say is that if you still potentially getting pregnant or you're avoiding STIs by using a condom, then the oil-based lubricants can interfere with the condom integrity. So water-based are much better. And these, again, can be used with HRT and topical estrogens, but again, use at a different time. Now, I mentioned earlier the importance of knowing when you can treat yourself or work with your healthcare professional, and also when referral is needed. And I guess some of the principles here apply without treating GSM symptoms. But if your symptoms don't improve on treatment, then we need to investigate why that might be and whether there's something else going on. We might look for signs of infection, and it's not unusual for women to and men of our age to have an STI or other signs of infection. I mentioned lichen sclerosis earlier, and I'm going to touch on that in a moment. Chronic pelvic pain, unscheduled bleeding, bloating that doesn't go away, any trauma, any potential introduction of foreign bodies, lumps, bumps, anything unusual, unplanned weight loss. These are all red flags to speak to your healthcare professional. Don't delay, and an appropriate referral can be made. And of course, keep up to date with your regular screening, such as your cervical smears. So lichen sclerosis, you may never have heard of this, or you may know a lot about it because you've had a diagnosis. It's a benign, non-cancerous skin disease that can occur in women, females of any age, even babies and young children. And it mostly affects the vulva and outer lips, but it can also affect the skin around the rectum. And actually what we quite typically can see is a figure of 8 in the area, and it can help, although it's not always easy to differentiate from GSM. The cause of lichen sclerosis is unknown. It's likely to be an autoimmune condition. It's not contagious, but the skin loses the elastin, it thickens, fibrin increases in that area. It can run in families, can be linked to conditions like vitiligo and thyroid disease. It really is very unpleasant. It causes intense itching and discomfort. The skin can become very wrinkled, thin, white, almost like tissue paper. The scratching that you can often do when you're asleep can cause bruising or even sores. And the inner lips, the labia minora, can shrink and disappear. And in fact, literally, the vagina can sort of really start to close, and it really is very unpleasant. Thickened skin may then cover the clitoris, which of course then has an impact on any sort of sexual pleasure. So diagnosis is generally made by observation and a biopsy. Even observing, gynecologists looking at a vulva that may have lichen sclerosis as a possibility may need to do a biopsy, or probably will do a biopsy to make sure of the diagnosis. Now, this is a chronic skin condition. There is no cure, but it can be managed effectively, and we need to catch it earlier for the better outcomes. And we do this with a strong steroid. Now, I mentioned earlier that lichen sclerosis can coexist with GSM, and particularly in our sort of postmenopausal years, it's a real possibility, in which case both the GSM and the lichen sclerosis need to be treated. It is important to get a diagnosis. Around 3 to 4% of people with lichen sclerosis can go on to develop skin cancer in the area, so a genital exam annually is recommended. So as part of our holistic approach to helping manage the symptoms of GSM, there's lots that we can do to help ourselves and to keep healthy. And of course, this helps us in many, many aspects of our health, cardiovascularly, metabolically, mentally, emotionally. So keeping a healthy weight, having a varied diet, which is high in plants, not smoking, drinking safely, taking regular exercise, are all important in maintaining our health, and particularly our genital urinary health. Taking pelvic floor exercises are key, and I hope you're all zipping at the moment to strengthen the muscles that hold everything in. Our pelvic floor, if you think about it, is a bowl of our pelvic floor muscles are a bowl that our bladder, uterus, and rectum sit. And as we lose tone, we know that. We look at our own muscles and we can see we're losing strength and tone. So this whole area will do unless we work it. So even just sitting here at the moment, have your feet flat on the floor, lean slightly forward so that you can feel your vulvar area in contact with the surface. And then with your hands on your thighs, try to lift the area around your vagina and anus away from the surface you're sitting on. I mean, I'm doing it now whilst I'm talking. It's just creating the habit. And draw up the muscles at the same time, squeeze, lift and hold for the count of 5, and you're aiming to build them up to a count of 10. So for those of us that have had children, we were absolutely taught how to do this and that we must do it post natally, but it's something that becomes even more important as we get older. And there's no excuse. We can do this while chatting to people, sitting watching the telly. It's just making it a habit. So try to do this exercise 3 times a day, or at least twice. Perhaps make it a habit while cleaning your teeth so you don't forget. You could, for example, add in 10 short, sharp contractions. Squeeze, let go, squeeze, let go, squeeze, let go. Now, if you need more motivation to keep going, then you can use tools and gadgets. There are some great apps. There's one called NHS Squeezy first, but if you think that you can't contract or relax your pelvic floor muscles, you're struggling to find them, then please seek help from a specialist. And your GP may be able to refer you to a pelvic floor specialist, continence nurse, a women's health physio, who can all help. And there's lots of resources on YouTube and the internet generally. And what we're trying to do is cure the lack of tone in the pelvic floor and improve it to a level where it doesn't bother you anymore. And I think the other thing to say is that estrogen can help with the responsiveness of that pelvic floor when you're doing the activities. If you've also got a prolapse or a partial prolapse, then a vaginal pessary can be inserted to really support the vaginal walls and pelvic organs, or you may need surgery. That's definitely a referral situation and something to talk to your GP about. The other thing that I want to mention is for those of you with urgency problems, bladder sensitivity, that feeling that you're going to leak or not quite make it to the loo, it is important to do some bladder retraining, and it can make a huge difference to life, just being able to go out and not worry about where the nearest loo is. So I think the challenge that we have is that if we've got urgency problems, we get into the habit of going to the toilet too often so that we're not caught short. So, that feeling that you've left the house, you do a wee before you leave, you go, a mile or 2 down the road, and then the first thing you need to do is go to the toilet. It's not because your bladder's full, it's just you've got into the habit of emptying it. It can make the problem even worse because your bladder gets used to holding less and less urine. It can shrink and then become even more sensitive. So bladder retraining is a method by which you can train your bladder to hold more urine. It does take determination, and it can sound a bit boring, but it really can have good outcomes. And what you're trying to do is cut the amount of times you wee in a 24-hour period. So again, tracking how you're doing, increase the length of time between the trips to the toilet, perhaps keep a diary to see what you're drinking and make a note of how many times you go to the toilet. Now, drinking too much tea, coffee, drinks with caffeine in it, alcohol, fizzy drinks can make it worse. So again, you can get some insight and awareness around what you're doing. Now, what about UTIs? I mentioned those earlier. And of course, the most common treatment for a UTI, urinary tract infection, is an antibiotic. And if you are troubled with recurring infections, that's 2 or more in a 6-month period or 3 or more in 12 months, you may be given antibiotics for longer periods. But if you're offered vaginal estrogens, and I really hope you are, to reduce the occurrence of infection, then it's a really positive move, as we've talked about earlier this evening. It's important to drink enough if you're prone to infections and have a wee before and after sex. If you're not always able to empty your bladder, then I would say try what we call double void. This means that after you've had a wee, wait 30 seconds and then try pee again. And I know myself, I'm constantly in a rush, have a quick wee, and actually what I realise is that I haven't properly emptied my bladder. So double voiding is a good thing to get into. And then what about washing? Well, we do see quite a few young women and girls who are teenagers who are getting a lot of irritation, and they describe it as thrush, but actually what's happening is that they're using douches, deodorants, they're shaving all of their hair, or worse still, using wax in the vulvar area. And we weren't designed to be naked. Hair is there for good reason. And by shaving and waxing, we're stripping off a layer of skin. If you then use soaps, foaming soaps, things with perfumes in them, it's a recipe for a sensitive vulval area. So I would say use a specialist vulva wash or something like Dermol or Hydromol, something that's non-foaming, or just simply water to clean yourself. Ointments are better for a very dry skin. I've mentioned already popping some stuff in the fridge, provided you remember to take it out. And be aware of some of the allergens and irritants in washing powder, fabric conditions. Again, anything that smells really nice has got a really synthetic chemical in it to make it smell that way. Wearing loose clothes, cotton, of course, natural fabrics is really helpful, and be aware of very dark things. So probably the worst thing that you can wear for the health of your vulva and vagina is a tight pair of black jeans, because the dye will leach chemicals into the area, and of course you haven't got free movement of air. So lots to think about that we can do to maintain the health of that area. Now, I want to say a few words about testosterone. We're going to cover it fully in the final webinar in our series in 4 weeks' time. But a theme that's run through this presentation has been the importance of our sexuality as we grow older, and low libido and sexual dysfunction is quite a complex area. We do know that replacing testosterone systemically as a hormone, we do that through the skin, can be very helpful for libido, but it's not going to be very helpful if we don't address the symptoms of GSM at the same time. And so making sure you get good professional advice around managing all of the symptoms around your sexual health is really important as you go through this phase, phases the rest of our lives, looking after our sexual well-being as well. So in summary, the majority of postmenopausal women, at least 7 in 10, will experience symptoms related to GSM. Only a small number of us will receive treatment. Most of us don't talk about our symptoms, not at least until we're asked, and we know that we're not being asked very often. Treatment is safe and usually works very well. And we know that estrogen deficiency isn't just about systemic symptoms, it's about the health of our whole genital urinary system. Vaginal estrogens can be used safely in the long term, and indeed, that's what we want to be able to do, is to use them forever. But a combination of different treatments can be used, including systemic and local estrogen together, as well as vaginal moisturizers and lubricants. Those of you that may have a history of breast cancer can usually be given vaginal estrogen. And finally, and some really good news, as a pharmacist who's worked in community now for over 35, 36 years, I'm delighted that vaginal pessaries can now be purchased under the supervision and in consultation with a pharmacist. So that brings me to the end of this presentation. There's a couple of extra things I want to do. One is to see whether there are any questions, and I can see here that we've got a number of great questions. First one, really easy to answer. Can I get a link to share with friends of around the same age? Absolutely, I'm going to send that out to you. Another question, am I familiar with biofilms in bladder and vagina that make treatment of problems in these areas more difficult? Jan, I'm not, I'm afraid. I'd have to read up in that. So I will get back to you. There's some other products available. Replens gives relief when intercourse is still painful. And for anyone that would prefer not to use HRT, then that is certainly an option. And I've got a question here, does using systemic estrogen or local estrogen stop the changes, lessen the change, or just slow it down? So both, actually. So if we're thinking about GSM, we can certainly use both systemic and local estrogen to help prevent the anatomical and pathophysiological changes of that area occur. And in some women, they can maintain the integrity of that area with the right kind of treatment. For some, it may be that they will still have a degree of symptoms. We're all individual. And I think that's probably covered most of the questions. There's a question around all the different hormones. We'll cover hormones in more detail in our next presentation. But if you've got any personal or specific questions and you want to book in a consultation, I'm going to talk to you about how you can do that in a moment. But you can also ping me an email. And if it's straightforward, I'll get back to you. So we've got a couple more left in the series. The next one's on HRT, 2 weeks' time, 21st of June. And then the final one is looking specifically at the role of testosterone and testosterone replacement. We're coming to the end. We're almost an hour in. Recordings are going to be sent by email within a week and will be in future uploaded onto our website. They're also going to be available on YouTube. If you want to scan that QR code, it'll take you directly to the website if you want any more information. It's been an absolute pleasure spending the evening with you today. Thank you very much for registering, showing an interest, joining and participating, and hopefully you'll attend one or both of our future sessions. Many thanks, everybody. Have a great evening.